Good morning and welcome to our very first Don't Forget the Bubbles ACP teaching session. I am absolutely beyond excited that you're all here, that we've had so much support online for this event. What it says to me is that this is absolutely needed. We definitely need a way to connect the paediatric ACPs across the country. And this is a real opportunity to do that. So I think we've got nearly 400 people signed up for this today. So thank you. You're connecting to a huge network of people that hopefully will be a great professional support to us all. We've got 3 short talks for you this morning. You're lucky enough to hear from 2 fantastic ACPs from around the country and me. And so we're going to be hearing from Felix Hay, who works in Leicester. He's done an amazing project on antibiotic use in tonsillitis. He'll tell you more about that shortly. And Ashleigh Lowther, who works down in Plymouth, who's going to be talking to us about ACP role in managing emergencies. I'm going to let them tell you a little bit more about who they are, and hopefully you'll settle in and enjoy the talks. We will have a short panel discussion at the end, so if there's any questions that you'd like to put to any of us, please use the chat function to do that. Feel free to tweet about this, and we'll keep an eye on those channels as well. So without further ado, I will hand you over to Felix. Have a lovely morning.
Okay, good morning everyone. My name is Felix and I am a paediatric advanced clinical practitioner working in the Children's Emergency Department out of Leicester Royal Infirmary in the UK. You guys could also find me online as shameless plug here for social media, Catman161 on Twitter. So I've got a lot I'd like to say about this subject. So fair warning, I'm probably going to speak quite fast, but please do use the chat function on the right hand side. And make sure you use that question button for any questions that you'd like to ask, and we'll try and collate those and answer them at the end. So, without further ado, today I'm going to be, I don't appear to have my my slides, which is a shame. I'm going to be talking about a topic that I find interesting. We'll try and sort that in a second. That I find quite interesting, but a lot of people might find a little bit mundane. And that topic is tonsillitis in children. So there we go. That's brilliant. So now I hope by the end of this, some of you at least might find the subject as interesting as I do, or even a little bit more interesting than you did before. So it's important to make clear from the start here, though, that the children I'm talking about are children who are systemically well with an uncomplicated presentation. So that's children that as soon as you've gone in the cubicle, that you've laid eyes on them and you're sort of 90% sure that you're going to be sending them home from the get-go, from the end of bed inspection. So first, let's have a look at how common this presentation actually is. Now, it's actually quite difficult to get national data on uncomplicated presentation of tonsillitis in children to tertiary centres. Public Health England tend to concentrate more on the invasive sort of infections where patients present as being systemically unwell. So what I did is locally at my workplace in Leicester, in a 6-month period that I audited, we saw just under 1,000 children that were diagnosed or received a diagnosis or a label of tonsillitis or pharyngitis. So tonsillitis, that proved to me that tonsillitis is a frequent attendance issue in the Children's Emergency Department. And now, because of that, you might think, or I thought before doing this, that there would be a fairly standardized way of managing this and that everybody might be doing the same thing because it's such a common presentation. This doesn't actually seem to be the case, or at least it wasn't where I worked. And I think we'll explore some of those reasons why over the course of this presentation. So now we've talked a little bit about the frequency with which we see this type of complaint. It's probably worth talking about what it actually is. And now, fair warning, we're going to be looking at some anatomy on the next slide, but don't panic. I like to keep things simple, so we'll do it in a very simple manner. So when we talk about tonsils, most of the time, instantly, everybody will think of those sort of large, bulbous, fleshy appendages that you see at the lateral edges of the oropharynx. And these are actually known as our palatine tonsils. However, we do have more tonsils than just those 2, as you can see from this image here, which is courtesy of Armando Hatterdungen, who I highly recommend you follow on YouTube and Twitter. So we've got pharyngeal tonsils, more commonly referred to as the adenoids. We've got the lingual tonsils, and then finally we've got the small tubal tonsils at the rear. And these are all actually collectively known as Waldeyer's ring. So the palatine tonsils are primarily the main structure that shows signs of infection, and indeed what we tend to inspect most when we're doing a throat examination. Tonsillitis itself is by its very nature an inflammatory condition. So when you see inflamed palatine tonsils, the entirety of Waldeyer's ring will also be inflamed, and this causes a lot of pain for children. And that pain is more often than not the primary reason that will lead to a child being brought to this ED by their parents. So why do we even need to talk about tonsillitis? Is there anything that we actually really need to worry about? Well, to me, the answer is yes and no, sometimes maybe, but in my opinion, mostly no. So why is it mostly no for me? Well, the simplest reason is one of numbers. The overwhelming majority of presentations of children with tonsillitis will be viral in their etiology, and then there'll also be some which are bacterial, but all of those cases, regardless of etiology, will be self-limiting. Now, what's the most common pathogen that we tend to associate with tonsillitis? Well, it's obviously group A beta hemolytic streptococcus, which we'll refer to as strep A for the rest of this, because that's a bit of a mouthful. So why do some people worry about group A strep? And this is a very interesting area of discussion, because the very simple answer, and this is very simple, by the way, it's a little more complex, is that we don't really need to anymore, and that's the caveat. So to understand why we don't need to worry anymore, we need to know why we used to have to worry about strep A tonsillitis. So as with any infection, there's always going to be the potential for complications. And now with strep A, there were some very specific ones that we used to have or used to worry about and still do have sometimes. And they come in two categories, and these are known as post-infectious complications or post-infectious sequelae. And they come under the categories of suppurative and non-suppurative. So suppurative complications are, as you may expect, ones that result in the production of pus, such as your main ones are quinsy, sinusitis, otitis media, cellulitis, and of course the big one that we see a lot of, or have been seeing a lot of recently, is scarlet fever. So your non-suppurative complications then, by contrast, are those that are not purulent or not producing pus. And these are anecdotally known as the big three, and the ones that people tend to worry about more as clinicians. However, only one of them is the root cause for the historical concern of people presenting with sore throat of potential strep A origin. And that is the fuel to the fire, that is the worry for those clinicians who feel that all sore throats must be treated with phenoxymethylpenicillin or penicillin B, which we'll call it now, because that is also a mouthful. So what are these sort of big three that we need to worry about or need to just think about? Well, the first one is glomerular nephritis. Secondly, we have Sydenham's chorea, and the biggest one that everybody worries about is rheumatic fever. So why do we worry about that last one? Why do we worry about rheumatic fever? So rheumatic fever sometimes can cause valvular heart disease later in life, which if missed can obviously lead to mortality. So quite rightly, this particular non-suppurative complication worries people seeing children with sore throats. The other two, by contrast, are not actually preventable, even if you treat a sore throat with antibiotics, so they tend to be less on people's radar or less of a concern. However, what we do need to ask ourselves is, do we even need to worry about rheumatic fever anymore? And the answer for that one, again, is fairly simple, and that is, for low-risk populations in the current climate of most of the UK, the answer is actually probably no. There are some exceptions, which we'll talk about in a bit. So the reason for this being that the incidence rate of rheumatic fever in low-risk populations, which encompasses actually most children and young people in the UK, is extremely low. So in fact, just to give some perspective or some history in the numbers, in the early 1950s, the number needed to treat for preventing one case of rheumatic fever was between about 40 and 60, depending on sources. And by contrast, today, it's actually over 4,000. So to put that simply, a clinician would need to give out over 4,000 prescriptions for penicillin B to prevent one case of rheumatic fever. And that case may not have even led to valvular heart disease later in life anyway. So when you add to this a decline in the prevalence of rheumatogenic strains of strep A, which is a bit outside the realms of this presentation, that we've seen over the last decade, the risk actually becomes even lower of having that as a complication. So I'll just move on slides. So what next? So what can we do to try and sort out the wheat from the chaff, so to speak, or in this case, the viral from the bacterial tonsillitis children that we're seeing. So there are various tools that I'm sure a lot of people will be familiar with, and the more common ones are sort of Centaur scoring, McIsaac adaptation, and fever pain. Now, I'm not actually going to dissect each of these three tools in any kind of detail, but I will comment that all of them share what, to me, I feel is an inherent flaw, and that's that they are all population-based scoring systems, which were based on disease prevalence rates and do not allow for sensitivity nor specificity when thinking about pre-test probability of whether a child has group A strep. So the score that we will obviously be most familiar with, or most will, and is recommended by NICE, is fever pain, and it certainly is the most recently created score, being created by Mark Little and his team back in 2014, and actually was off the back of a very well-designed study with a very good large sample size. However, its precision, like the other two scores, is less than ideal, and its accuracy is based on, as I said, the disease prevalence for the population being studied at the time. So to give an example of it, even if you score the maximum amount of points possible on the fever pain score, its positive predictive value that the etiology of the sore throat in front of you is still only circa sort of 63%. So what we need to ask ourselves is that if the best scoring system we have available to us only gives us a positive predictive value of slightly more than the toss of a coin, then wouldn't we want to get a better tool or something with more precision? Obviously, the answer to that question, to me anyway, would be yes. However, for me, it generated a different question, and that is, if the only thing that we as clinicians used to worry about was rheumatic fever and secondary valvular heart disease, and that's no longer a concern in our current climate and population because it's almost never seen, do we even need to treat confirmed group A strep? So luckily for us, there's actually been a lot of work done on this, and it's been looked at extensively. There was a Cochrane review in 2013 by Spinks et al., and they deemed that the answer was not really, or maybe. So the review found that the benefit of oral penicillin B for 10 days at QDS, a 4 times a day dosing regimen, was only just up to 16 hours of less symptoms of tonsillitis. There was no significant increase in suppurative or non-suppurative complications, and the same decrease in symptomology was actually seen when compared with other studies that used just ibuprofen, topical anti-inflammatory medications such as Diflan spray, and adequate oral rehydration being cared for in the home by parents. So the groups that in those studies were administered penicillin B also were seen to have mild gastrointestinal disturbance in the form of vomiting and diarrhea. Now, I found this one quite an ironic side effect, as one of the main concerns of children presenting with sore throat is actually dehydration. So administering a treatment that may cause further fluid loss seems a little bit illogical when the evidence suggests that a more supportive treatment approach, such as NSAIDs, Diflam, and an adequate oral hydration, is just as effective with no significant outcomes associated with that. In fact, a guideline that I very much like by the Scottish Intercollegiate Guidelines Network recommends this supportive management approach in low-risk patient groups. So I've talked about high and low-risk groups a little bit so far in this presentation. So who is it that we actually need to worry about, and what do we do for them? So quite simply, the following children are considered high risk and should receive oral antibiotics if presenting with symptoms that the clinicians feel are commensurate with potential strep A throat infection. And those groups are children from immunocompromised groups, so your children with cancers or those with syndromic conditions that may affect their immunological response, such as trisomy 21, Q deletion syndromes, etc. Those certainly with congenital cardiac anomalies, and obviously, as I've mentioned, hematological and oncological issues. Other groups that we should be giving antibiotics to when we see these things is obviously those with existing scarlet fever or barn door scarlet fever. Those that have existing rheumatic fever, I feel like that shouldn't need to be said, but it's definitely in there in the literature. And those with a recent contact with a serologically or culture confirmed group A strep sufferer. So those are your sort of high risk groups. So we've got low risk groups as well, which I'll come on to in a second. There's certainly groups of people that have a genetic predisposition to being more at risk of rheumatic fever, and that's children from the Pacific Island areas, so Australia, New Zealand, Micronesia, Polynesia, Indonesia, Tasmania, and then some rarer ones from the circumpolar regions of the world, like native Alaskans and Canadian Arctic Aboriginals. But I certainly don't see many of those in my practice. I'm not sure about others. So obviously, if we've got high risk groups, we're going to conversely have lower risk groups, and those low risk group children can be treated with the supportive approach that I was discussing. And those children are children that don't have any of the above and under 5 years of age, particularly those under 3 years but above 6 months of age, and also children that have had no recent contact with serologically or culture confirmed group A strep. Whew, breathe. So now what? What do we do now? So where do we go from here, and how can we as clinicians improve our practice? Well, for me personally, it's all about clinical risk stratification. So whilst our population-based scoring systems could definitely do with improvement, they're currently all that we have to guide us in clinical practice. And that's why the fever pain score especially is recommended by NICE, and you will likely see it used in practice, or you probably currently do use it in practice. There is a large consensus from multiple high-tier evidence reviews that in the majority of cases of sore throat, they are of viral etiology, and even those that are bacterial will normally self-resolve with supportive therapy without significant sequelae. So for me, if the child in front of you is systemically well, and then not from one of those high-risk populations that we were talking about, the clinical risk of a negative outcome by not treating with penicillin B, even if it is a bacterial throat infection, is actually statistically fairly low. So personally, in my practice, I like to consider net benefits versus net harms when prescribing any medication. But for me, penicillin B, I don't know if anybody else has tasted it, but it tastes absolutely hideous, and it can cause acute losses through vomiting and diarrhea. And it only gives up to 16 hours of relief of the negative symptoms associated with a strep A throat infection. There is pretty good evidence that the same outcome can be achieved in the same time frame with ibuprofen, Diflam spray, and adequate hydration, and that children actually comply with this second regime much better. So why my question, I suppose I'll end with, is why would we choose option one? Thank you very much.
Hello everyone, Felix, thank you so much. You are clearly incredibly knowledgeable on that subject, and I saw a couple of questions coming through which we will be able to direct to you later. So I'm going to let you relax for a few minutes while I give my presentation, and then we'll hear from Ashleigh before we all join in for a bit of a discussion at the end. So I'm going to talk to you about the management of lymphadenopathy in the emergency department. I don't know how you feel when you're going to see a child who's perhaps got some sort of lump. So let's imagine you're going to see a child who's been triaged, maybe a child who's come with a bit of a fever, and the triage nurse says to you, Mum thinks he's got a bit of a lump in his neck, or I noticed a lump when I was taking his temperature. What does that make you think? So if you're anything like me, you're thinking, oh God, what am I going to do about this? Who should I treat? Who should I not treat? Who needs bloods? Who needs an ultrasound? And how am I going to make sure I don't miss a child with cancer? So this is all a bit of a challenge. It's one of those grey areas. And I think there's probably no absolute answers to any of this, but I'm going to talk you through my strategy and how I think about these children as I start to approach them. So the first thing to say is lymphadenopathy is common. About half of under fives are going to have palpable lymph nodes in the cervical region, even if you just meet them at a well child check. And most of those are completely benign. If you want to think about how you might approach these children, then history is absolutely the key. So the differential for lymphadenopathy is incredibly broad, and ideally we want to have some sort of an idea about what is likely to be wrong with this child before we even lay our hands on them. So have a think about history. A few days of lump is likely to indicate some sort of inflammatory process, and a few weeks is likely to be something more serious. So really have a think about how long this lump's been here and whether it's changed in that time. In your history, make sure you cover things like recent illness, whether the child's had a fever, whether there's been any anorexia or weight loss, has the child had any fatigue, and have they had any recent travel? Probably not at the moment. Any exposure to animals? Have they already been treated for some of this? And if so, was there any response to treatment? If the parent noticed the lump, then ask them, when did it first start? What did it look like then? And how has it changed over the time? Think about size. So size matters a bit. First of all, the size of the lump, and secondly, the size of the child. So generally, 1 centimetre or more of enlarged lymph node is considered to be large. Those over 2 centimetres are more likely to need some sort of investigation and treatment, and that might be bloods or an ultrasound, and we'll talk about that in a minute. Equally, the size of the child is often a clue. So kids under the age of 2 are much more likely to have reactive lymphadenopathy, and that might occasionally progress onto an abscess, but the vast majority of those are going to be benign. Malignancy is much more common in the over 6s, so it's worth just having that kind of age differential in your mind. Think about the location of the nodes. So we often think about cervical lymphadenopathy giving you being a benign reactive lymphadenopathy. So we see small, soft, bilateral nodes, which are likely not to be tender, and they're not likely to have underlying skin changes. These kind of nodes that you might find in the cervical regions are likely to be lymph nodes that you happened to palpate, rather than those that were part of the presenting complaint. But it's really worth trying to get a sense of what those nodes are reacting to. So that kind of lymphadenopathy might be associated with some sort of viral illness. It's likely to be an upper respiratory tract infection, maybe tonsillitis or otitis media. But think about where the lymph nodes are draining from and look for infections in those areas. For example, you might see children with scalp infections or an oral or dental infection. The lymph nodes in the submandibular region and the upper cervical regions are often more associated with bacterial lymphadenitis, and often those kind of lymph nodes are unilateral. And thinking about not wanting to miss a diagnosis of cancer, the red flags there are multiple nodes over multiple sites. So not just a few shotty lymph nodes in the cervical region, but also children who might have lymph nodes in the axilla or the groin that you can feel. Children with supraclavicular nodes are more at risk for malignancy, and equally those with systemic symptoms that you've already ascertained in your history. So think about where those nodes are. It's really important just to have a really good idea of the anatomy, and that will help you to work out where those nodes are likely to be draining from and which ones are likely to be problematic. Have a feel of the lumps. How do they feel? Are we talking about a few mobile pea-sized lumps in the back of the neck, or are we talking about a single grape-sized lump? The single enlarged nodes are much more likely to be associated with either significant infection or malignancy than the small shotty nodes, which are much more likely to be associated with just reactive lymphadenopathy. The key here is the child unwell? So if you're thinking about a child who may have lymphadenopathy related to something more serious, for example, Kawasaki's disease, or at the moment PIMS TS, then those are likely to be children who are looking unwell. They're not well children who are running around the waiting room and happen to have a bit of a neck lump. Look and just check whether that lump is distorting any normal anatomy or whether there's any induration or ulceration over there. About 25% of patients who've got bacterial lymphadenitis are going to have fluctuants in that lymph node when you examine it. And that's especially true with the ones who are infected with staph. So you should be able to feel that when you palpate the lump. And the small, mobile and non-tender ones are generally not concerning. Again, make sure as part of your investigation, you do a full top-to-toe examination. Look for any associated liver or spleen enlargement. Those are much more likely to be associated with malignancy, and those you're going to need to investigate a bit further. So in terms of lymphadenopathy initiated by an inflammatory response, there's a real spectrum. So once you've managed to ascertain which ones you're worried about from a malignancy perspective, and you've kind of put them in their separate group where they're going to get blood tests and referral and clearly some follow-up, then the rest of the group are probably likely to have some sort of inflammatory problem. And this spectrum is wide and varied. So at one end of the spectrum, you've got children who've got benign reactive lymphadenopathy. These are kids who are essentially well. They've often got multiple lymph nodes, but they're small. These don't need any treatment at all. They can be reassured they'll get better on their own. At the other end of the scale, we've got children with a large tender node. And those children often do need some sort of investigation and potentially some treatment. So what is that? So which of these children need blood tests? So the answer is probably not many. It's actually not likely to direct your management in many cases. So unless you're worried about malignancy or systemic infection and you're doing blood tests for that reason, you don't need to do blood tests just on the basis of the lump alone. We've talked about other infections like Kawasaki's disease and so on. Just also bear in mind that some children have enlarged lymph nodes as a result of cat scratch disease or mycoplasma. Those are likely to be much more chronic problems and will need longer follow-up. The nodes that potentially benefit from investigation with ultrasound are those that are probably over at least 2 to 3 centimetres. They're likely to feel fluctuant, and those are often ones that you might consider referring for an ultrasound and talking to the surgeons about, so that they can decide whether they want to drain that or whether to initially treat with antibiotics. The ones that are kind of borderline, maybe less than 2 or 3 centimetres, a bit inflamed and a bit tender, but not obviously pointing and where you can't obviously see pus at that stage, those often do really well if you give them a course of antibiotics and follow them up. They clearly need to be safety netted so that if that lump is progressing, if they're getting lumps in other areas, or if that lump is looking like it's becoming infected and ready to pop, then they need to come back and we'll have a think about drainage. So the key point about children with lymphadenopathy is that actually most of them are well. So a good history can really help you differentiate between those with a higher risk of malignancy, because they're the ones who've had ongoing symptoms. Equally, a careful examination is going to help you to direct management for those with inflammatory processes, and you can decide where on the spectrum those kids are, whether they're the ones that you can reassure or whether they're the ones that may need some investigation and some antibiotic treatment. Either way, all of those need our usual safety netting, which can mostly be done by parents. As long as you're clear with what your expectations are, they can very safely go home and just come back to you if they're worried. Okay, thank you very much. I'm going to pass you over now to Ashleigh so that she can talk to you about ACPs in emergencies.
Thanks, Becky. I'll just wait for some magic to appear for my slides to come up. Okay, thanks very much. Thank you, Becky and DFTB for allowing me to take part in this morning's teaching session, which is just going to be, it's a great opportunity for us all to get together and just talk about some of the things that we may find more difficult in the workplace, or that we just need to have an agreement on, really. I've started a poll in the, so you'll see it on your sidebar, that I'd like you all to vote on if you can. And we're going to do the same poll at the end as well. So what am I going to, so who am I? So my name's Ash. I'm an ACP in emergency medicine down in Plymouth, by the sea. And if anybody's looking for a job, stay on the line afterwards and we'll have a chat at the end. So my background is emergency nursing and the military, and I'm really interested in resuscitation, really sick people, including children and adults. And I love working in resus more than anywhere else. So why am I going to talk to you about this? Because I think ACPs have a really unique role to play in resus, especially in the resuscitation of adults and children, based on their background. We all know that big cases, cardiac arrests, traumas, are complex, they're busy, they're multi-professional, they have lots of people. And sometimes it can be quite hard to know where ACPs fit into that. Should ACPs be back out in majors, cracking through the queue, or BMPs cracking through the queue, or should they be in these big cases? And that's quite an interesting thing to debate, really. So I put the poll up, so feel free to have a vote on the poll. Just a slight disclaimer, all the photos used in this presentation are free open access photos, mostly used from an app called Splasher, which is people who use photos and share them make them available for widely sharing. So without further ado, I'm going to tell you about a situation. So see if this works. Doesn't look like it's going to work. Okay, so it's not going to work in that way, but let's imagine you are in ED and the red phone goes. So you're either an ED ACP or trainee ACP, or you might be, as a lot, you might be a PEDS ACP carrying the crash bleep. Whatever way you would normally get called to the resus room, the resus room has the phone has gone off, and the only thing that you remember, this is not what it's meant to say, ignore that. The only thing that you remember is 4-month-old baby. So for some reason you don't take anything else in that's said on the app list other than there's a 4-month-old baby coming into resus. So whatever your role is around the hospital, you're going to be in resus in about 15 minutes. And at that point, your heart's started beating quite fast. Your mouth's gone really dry, your hands are a bit sweaty, and you feel a bit out of your comfort zone. For some of you, a lot out of your comfort zone. The key thing to say really is that it's completely and utterly normal to feel like that. This is where ACPs really come into their own. So your comfort zone, if you're like me, or previously like me, is to say, right, I'm going to go and work alongside the nurses. I'm going to use the IO, the rapid infuser, get the drugs drawn up, go through CPR with the nurses. I'm going to do what it is I've always done and be that kind of be that support. And that's a really, really good thing for an ACP, because we are, in my opinion, a really good link between the medical and the nursing team, because most of us have come from that background. Obviously, loads of ACPs that are paramedics, physios, and we've all got different backgrounds, which we can bring to those situations on what we would do normally. But what I'm trying to say is the default is to move back to what you've always done. This is where you need to step out a little bit. So let's go back to this case. So all you heard was 4-month-old baby. And it's based on a real case. So this was my first week as a trainee ACP in my last trust, where I started my ACP journey. And I was working with one of my colleagues who was a really senior ACP, the kind of guy that I would trust to look after any of my family members, any of my friends' children, anybody. And we'd known each other for a number of years. We were both Resus Council Advanced Life Support instructors for peds and adults. We'd both been in the military. We're both now on the ACP pathway. So I arrived at my first shift in this hospital. So in my last job, we covered 2 sites, one busier trauma unit and one smaller local hospital. So I'd done some shifts in the other hospital, and this is my first shift in the smaller. And it was 20 to 8 in the morning. We'd had a coffee, and the red phone went, and there was a 4-month-old baby coming in cardiac arrest. And my mentor said, right, let's go, we're going to resus. And I have worked in resus many amount of time, but I felt horrendously uncomfortable. I just felt like this wasn't right. What was I going to do? This wasn't the right thing. I wanted to just have a nice, gentle introduction to the department and see how things played out. So it was me, my mentor, and another ACP, again, another instructor in paediatric advanced life support. So it was 3 of us, 3 or 4 nurses, and we put a MET call out. So my colleague delivered the brief, delivered a really good team brief, allocating appropriate roles, airway management. He allocated me IO access, which is something I was superbly comfortable with, but it didn't feel right, and it felt really different being allocated that role as a trainee ACP to being allocated it as a nurse in resus. And I didn't really know why, but I didn't feel good. So we allocated all the roles, and then the paediatric MET team arrived, and my colleague continued to brief the team and got them involved. And about a minute before the child arrived, or the infant arrived, the paediatric registrar said, "Oh, no, this should definitely be led by a doctor. A non-doctor can't lead this kind of case, so I'll be the team leader." So then swapped places with my mentor, and then the infant arrived. There was no rebrief. You could have heard a pin drop. There was so much silence. I just want you to have a think now and pop something in the comments in the chat if you like, but how do you think the team will have worked together after that kind of introduction, that kind of sort of human factor shuffle around? Because in this case, it was just silence. There was just, you could have heard a pin drop. The infant arrived, and as predictable with a lot of these cases, it was quite a short-lived resuscitation. It was very sad, and unfortunately the child did die. And we had a debrief. The A&E team, or the ED team, had a debrief, but the paediatric team weren't really involved in that, and that was a problem. But you know, the real problem of the situation should have been discussed with peds, but it wasn't. So we had a bit of a debrief, and I came away feeling absolutely horrendous. I felt really like, what have I done? This is terrible. I would have felt so different if I was the nurse in there. I felt really different because I was the trainee ACP in there. And I felt, why did it feel so different? And then it took me a while to realise why I felt different. Because about 2 months later, so still very early on in my journey, I put a Selding or chest strain in. And I was all dressed up in my sterile clothing. And I genuinely thought that somebody was going to come up to me, rip my clothes off and say, "What are you doing? Stop messing around, Ash. Get the 3-lead ECG on. This is not, it's not time to start trying to think you can do more than you're qualified to do. Remember your job, remember your role." And I realised very quickly what this was. Now, this is a very busy slide. It's not come out with my animations again. It's not meant to be like this, but I will... you won't be able to see it, but in the background, you'll just see a poster that we created, which is too busy for a slide. I put it in intentionally so that Ross Fisher would get annoyed, because he'd be very unhappy with that level of slide. But it's just to show you that a year after I became a trainee ACP, I realised what all this was, and it was called Imposter Syndrome. And it's very, very normal. So what is Imposter Syndrome? Well, it's it's really normal in high achieving people. It's really normal in people who step outside their comfort zone on a regular basis. And it's really normal in ACPs. In fact, it's really common in people who work in emergency medicine in general. So we presented this poster at a conference, and really the key things for me were looking at this phenomenon and relating it to my Seldinger chest strain and my pediatric cardiac arrest, and thinking, well, if we know it's a thing, how do we use it to our advantage so that we can step into the roles that we need to actually do? And for me, the key things with imposter syndrome is you think everyone has got their life together. You think everyone else has got it sorted. Look at him, he's not even worried, he's not stressed. Look at her, she's all over it. But actually, a lot of people who won't tell you are suffering from imposter syndrome. So the other thing it says is that you attribute success to luck. And I talked to so many ACPs and training ACPs saying, oh yeah, I was really lucky to get this job. I spent my whole life going, I was really lucky to get in the RAF. Yeah, I was really lucky, must have been really lucky on the day. I was really lucky to get my A&E course. Yeah, I was really lucky to get my ALS. I was really lucky to get everything. When actually, it's often not luck. And actually, in emergency medicine and healthcare in general, and certainly in the ACP world, we're actually quite a driven bunch. And so a lot of it is not luck. A lot of it is actually, we're just quite driven and we push ourselves to get to that next level. So let's just quickly take a look at the attributes of a pediatric cardiac arrest, because the aim of this slide was the only way to get around imposter syndrome effectively is to push yourself out of your comfort zone. And that is the key from the poster we presented. Things like feedback, things like MSFs, things like formative assessments are the things that will push you more and more away from imposter syndrome and into comfort. So I was just thinking about what really is required. So let's back to our 4-month-old cardiac arrest coming into resus. What really is required from that team? And looking at a sort of Venn diagram, experience and knowledge is key, but how do you balance the two? So you need knowledge, and you need a team who are APLS trained and know what the algorithm says we should do for a pediatric cardiac arrest. But that's balanced nicely with experience, isn't it? Of knowing that the algorithm doesn't always work, and it's not always as simple as going through like you do on a simulation. In the end, you have a debrief and it's all nice. You've got a lot more additions, and the fact that you're in a busy department, there's other patients, there are unseen human factors of people having a really bad day or being new to the department or a bit of kit not working or the bus was late this morning. So actually you need experience as well to know how the balance works. You need the skills. You need a team of people who can manage the airway. You need someone who can put an intraosseous device in or an IV cannula in as appropriate. You need someone who can use a defibrillator. You need someone who can give drugs. And you do need someone who can lead and bring all those things together. But you do also need that other team to have the ability to be good followers. And I believe that to have a good team who will follow you is dependent on the strength of the leader. And really, the leader can make or break this situation in terms of their ability. So can an ACP? The question is, can an ACP fill any one of these slots? And I really truly believe that you can. If you're aiming for becoming a leader of a cardiac arrest or a trauma, the unique ability of an ACP is that you'll probably have done every other role within the team at some point. And it can be really easy to fall back to, most people who are on this webinar will probably know if I said to you, how do we make up Comoxclav? They'll know because we've done that role, so we can pull out our old skills. But that actually makes you a better person as a team leader, because when you allocate a task, you know what that task involves. And you can probably tell by the look on someone's face whether they know what that involves, and that means you're able to edit the way you do things. So I think that all of those things lend themselves very nicely to an ACP. All of us can do pretty much every part of that, and the way to get involved is just to be in the room with adults and children in cardiac arrest, in traumas, to get experience of how that feels and to get experience of every single role. ACPs are, so the picture behind the roller coaster, by the way, is a picture of someone overlooking a vast kind of plane, so from a high up position. Most people who become ACPs, especially those in paediatric emergency care or in emergency care, have come from a position of seniority, be that a senior paramedic, a senior A&E nurse, a senior paediatric sister. And so that most of us will agree, when you're in that position, but you're a nurse still. So for me, I was the nurse in resus who wanted to do more, who wanted to so looked at what was done and thought, I could do that. Yeah, I reckon I could do that. But be under no illusion, as soon as you step foot into the training ACP world, that all falls away, because you will have a roller coaster of a journey where you go from thinking, I just admitted someone with a STEMI, was that the right thing to do? Should they really have come into hospital, or could I have sent them home? Whereas before, you could be a nurse in charge of a department going, that's probably coming in, going home, going home, going home. And that's the difference. But you have to be prepared for that. And that allows you, in fact, to be a much better person within this team. So it's all about pushing yourself out of your comfort zone. It's baby steps. And the way in which to do it, I love this photo, the way in which to do this is just to place yourself in the environment, but also to get feedback and to get formative feedback on a regular basis. So in terms of resus particularly, you just need to put yourself in there. When that red phone goes and you hear 4-month-old baby, put your hand up and you say, yes, please, I'd like to go. I'd like to go and work with that person. I'd like to do that role. Try and just be in the room. If you've answered no, as you don't feel like you're the person that's going to lead that, how are you going to get there? And it's small steps and review of others and others reviewing you. Formative assessment is so powerful. It is really the way to do things. Seek assessment, seek feedback, and find a really, really good supervisor. So absolutely, you can do it, just being in it, reflect exposure, get feedback and review, because absolutely ACPs can do this. I'm going to refer you to some really good sites, because there's only a small chat about this. If those of you doing RChem credentialing, PMP3 and PEMP4 are what this talk relates to. So have a look at them. One of them in particular is about resus room equipment and protocols. Start that early, start it in year 1, get a formative assessment in year 1, get a formative assessment in year 2, and then get a summative assessment in year 3, so you can build on it with every role that you do. Colleague of mine, a friend of mine, Dr. Claire Masanko, does a really, really good talk on all of this, but a bit longer, and the case she relates it to is a paediatric cardiac arrest. So I really, really implore you all to go and watch it. And she talks about how we are going to be stressed no matter how senior you are. These situations are never stress-free, but how do you turn it into performance? How do you really embrace the feeling and make sure that you deliver top class performance? And then the other link is, and I'll get the guys to link it in the chat so you can follow the links, just about the history of imposter syndrome and how it's actually really common, and it's probably a good thing. If you look at your colleagues who say, I've never had it in my life, I'd worry about them more than those who do. That's it for me. Thanks so much.
Hello again. Thank you, Ashleigh. While you get your breath back, and while Felix comes online, hi Felix, I just want to draw your all attention to something that you hopefully have received, a link so that you can get a discount code for our upcoming DFTB live and connected conference, which is taking place in August. I think Tessa's going to post a link for you now. That is going to be a fantastic event, which is going to be streamed internationally. We've got a fantastic mix of speakers, including Rob Delaney and Ronks, and also some opportunities to connect with each other in breakout rooms, and some surprise entertainment. So please join us for that. Use your discount link, which is really just a thank you for supporting us all with this very first ACP webinar. The other thing I want to do is just shout out to somebody who's got a birthday today. So very happy birthday to you, Kerry Magnus. I hope you're having a lovely day, and thank you for spending part of it with us. So we've had quite a lot of activity on the chat. We've just got a few minutes left. And I just wanted to pick up on a couple of questions that came out of Felix's talk, first of all. So the first question is, Felix, do you use amoxicillin rather than Pen V if you are going to use antibiotics? The comment is we thought the evidence was showing that when antibiotics are required, this is better tolerated, and I think people would love to hear your thoughts on that.
Yeah, no, it's a very commonly seen, isn't it? So I don't disagree with the fact that children tolerate amoxicillin much better, purely because it's much less bitter than penicillin V. The reason I wouldn't give it is purely because of how well it covers or treats potential Group A strep, and that's purely because penicillin V, Group A strep is a beta-lactamase producing pathogen. That is an enzyme that this bacteria produces to try and resist being killed. So penicillin V has a very robust beta-lactam ring and is known as a natural penicillin. So the other natural penicillin is penicillin G, which is also an effective treatment for Group A strep. Amoxicillin is what's known as an aminopenicillin, and whilst it does contain a lactam ring, a beta-lactam ring, it isn't actually specifically as good at treating Group A strep specifically, and is often why, when you're thinking about beta-lactamase producing pathogens, you will probably go for something like clavulanic acid additions, not specifically in the case of pharyngitis or tonsillitis actually, but purely because clavulanic acid, the part of co-amoxiclav that you have is actually what's known as a beta-lactamase inhibitor. So rather than destroying it, it stops it from being generated. It stops the pathogen from generating it. So in other situations where you're looking to go to second line and more broad spectrum, you might where you've got invasive Group A strep specifically, you might look to that. But as well, co-amoxiclav I don't think is a great choice for a tonsillitis. I think if you're going to give antibiotics, it should be penicillin V.
Okay, thank you. And another question on that note, and I think this is something that some of us struggle with, although I think a bit less recently. How do you find that parents respond to you not giving antibiotics?
So the quick answer to that is variably. I think it depends on how the interaction has gone in terms of the consultation from beginning to end, managing figuring out what the expectation is from the get-go. So and also past experience. So a lot of the time when you go to see a primary care physician, for example, they very quickly will reach for the green pad and give the prescription for Pen V. So if that's what you've always had when your child has recurrent tonsillitis and then they've got better, you perceive that is causality rather than it just being chance correlation. So it would be likely that if you left that throat infection, it would have got better by itself, regardless of it being viral or bacterial anyway. So if parents aren't, and we shouldn't expect them to be, they're not well versed in statistics or numbers needed to treat. So I don't often go down that route of saying things. What I do say to parents that I think have a level of understanding that would be commensurate with me having an impact on them is I will talk to them in terms of sort of numbers or percentages and say, we know that antibiotics can help children, and by help I'll define that as being they can have less pain at day 3. But we also know that if you were to give 6 children the same antibiotic prescription and they're all the same as your child, only one of them would actually receive that benefit. So I make it a bit easier to understand rather than saying what the number needed to treat is to have an effect. Because when you say 1 in 4,000, that won't be fathomable at all in real terms. So I just say about 1 in 6 children will see the benefit of penicillin at day 3, but within 1 to 2 days, you can get that same benefit by just using Difflam spray, ibuprofen, and oral rehydration. So I just try and manage it on a case-by-case basis, but I understand and acknowledge that if you're in a primary care setting, that could be extremely difficult to do in 10 minutes.
Yeah, absolutely. And as ever, it's about how you tell it, isn't it?
Yeah.
It's all about the messaging. Yeah. Thank you. So there's been lots of chat, Ashleigh, about ACP role in resus and how people are being received, and I think there's a real range of people's experiences there. I personally am incredibly lucky that I'm very well supported in the department I work in, and I am able to run emergencies. I wonder whether you've got any top tips either for us as ACPs or you know, for the department as a whole about how we can just make this better, because clearly we've got a lot to offer.
Yeah, absolutely. So actually, just quickly want to refer to the poll, because the poll says it all. So the first poll that I ran was 45% to 54. So 45% would, 54 wouldn't. And the secretary ran it at the end of the presentation. It was 72 to 27. So actually, there's the answer. The answer is it's us that can change it. A lot of the time when we think that the department and the trust don't want us to do it, it's not that. It's that we don't think we can do it, and therefore we don't ooze the confidence that's needed. Also, it's a really, really fine line, isn't it, between confidence and competence? And the worst thing in the world, and I've seen it many times myself, is an overconfident ANP or ACP. So the answer to your question is, it's true, you know, there's nothing worse than using the terminology, I'm just the same as you, or I'm better than you, or I can. It has to be baby steps. And would you mind if I led this cardiac arrest? Because I really think that, given my EPLS background, that I would be able to do it. And I'd love you to do it with you standing on my shoulder. Actively ask people to watch you do it. It's the way to change culture within a department and a system is to invite, and the classic John Hines presentation from SMAC is to invite the skeptics to do it with you. Stand on your shoulder, deliver it, do it, and do it well. And then ask for feedback and take that feedback on board, because then they go, oh, actually, he really does want to get better. So yeah, that's that. And I'm like you, Becky. I'm really lucky that I've got a fantastic bunch of consultants who will happily hand me the Atmos. I spend my time now giving it to the F2s and that, because it's really easy to fall back on your comfort zone, but now it's important to push it to everyone else, and it's really appropriate that everyone gets a chance to do it.
Thank you. And I'm going to also direct you all to a reference on the permeable practitioner, which somebody has posted, and we will link to on Twitter in a minute. So we're just about to finish up now. So I just want to thank you all so much for joining us this morning. This is the first ACP session. It's been a great success from my perspective, particularly in terms of the way that we have managed to connect all of us. And I don't think there's any other way in which ACPs are being connected in this way. So let's keep this up. As I say, we've got our next session in August is going to be the DFTB Live and Connected conference. And so we're going to pick up our ACP sessions again in September. If you would like to volunteer to speak with us, or if you've got any ideas for topics you particularly like covering or speakers you'd like to hear, obviously we'd love to hear from you. This session has been recorded, so we'll be able to share that. You can watch it back again, and you can direct your colleagues to it if they weren't able to make it today. Please get in contact with me via Twitter and let me know how today was for you. And again, if you've got any burning desire to come and speak with us. Thank you so much to Felix and Ashleigh. You've been absolutely amazing. Thank you for stepping up to the first session. I'm really, really grateful to you both. Thank you.
Thank you, Becky. Thanks, everyone.
Okay, bye-bye.
Bye-bye.